Today's lecture is on radiotherapy for lung cancer with the emphasis on stereotactic ablative radiotherapy. And our speakers today are Dr. Bill Lou and Zi Wang. Dr. Lou is a full professor and a director of thoracic radiation oncology in our department. He is also a recognized expert on stereotactic ablative radiotherapy for lung cancers and one of the authors on NCCN guidelines. He's also quite an amazing innovator. We are very, very proud of him here. He's one of the smartest people I know, for sure. He's building a new flash machine. Flash is an ultra high dose rate machine. Together, it's a project between Stanford Radiation Oncology and Stanford Linear Accelerator Collider. And he will have later on in a lecture series, he will have a lecture on flash, so stay tuned. He used to be a resident here, as many of our faculty, and now he is quite a successful, renowned radiation oncologist. He's been recently awarded Fellow Astro and ACR. He also has many, many awards for teaching and research, so we are very proud of him. And Zi Wang, he's our great dosimetrist. One fun fact about him, he used to work at Harvard with Thomas, and now we stole him from there to work for Stanford. So he will teach us today the treatment planning for lung SABR and also conventionally fractionated VMAT. But first, we'll start with the clinical lecture by Dr. Lou. Take it away, Bill. I will stop sharing.
Okay, well, thank you so much, Natalia. That was too kind of an introduction. I appreciate that. So I'll be talking mostly about SABR, but Natalia asked me also to cover just a little bit about conventionally fractionated radiation for more locally advanced lung cancer, and just touch on a little bit of flash at the end. I'll focus mainly on the clinical aspects and data, and then Z will cover more of the technical aspects and planning. I'll go a little bit fast. Forgive me for that, just to leave enough time for Z. So I think there's a current evolution in thinking about the approach to lung cancer. The classical approach to treatment is based on this understanding of stage, which is that early stage lung cancer, which is localized to just the lung, of course, has the highest survival and best chance for cure. But unfortunately, only a small minority of patients are diagnosed at this early stage. So the early stage is where SABR has really become one of the standards of care, as we'll talk about. In locally advanced lung cancer, this is where there's metastasis to regional nodes. About a quarter of patients are diagnosed at this stage, and of course, the survival is much worse, although it is evolving quite dramatically. So with the current modern combinations of chemo, radiation, and adjuvant immunotherapy, we're starting to see survival exceeding 40% at 5 years. So that's a big evolution in recent times. And then metastatic disease is where most patients are diagnosed. The survival is much worse, of course, but again, we are seeing some improvements, especially with the addition of immunotherapy, with now starting to see a little bit of a tail on the survival curve, even approaching as high as maybe 10%. So a few patients may even be cured with systemic therapy, especially immunotherapy, but the large majority are not. But this is one area where radiation is starting to play an increasingly important role. And that's illustrated here with these newer concepts. So again, we have metastatic disease, but now we're starting to recognize entities such as oligometastatic disease, where there's a small burden metastases, and some of these patients can be treated with the potential for cure. And then there's also the concept of patients with metastatic disease. They may be getting systemic therapy and responding overall, but at some point they eventually progress. But some of these patients progress in only a limited number of areas. We refer to this as oligoprogressive. And again, this is a potential for newer radiation treatments to have an important role in improving the overall treatment and increasing the effectiveness of different lines of systemic therapy. Okay, so stereotactic ablative radiotherapy is now, I would argue, a potential treatment option in stage 1 to 4 lung cancer, as we'll talk about. In early lung cancer, it is now the standard of care for patients who are unable to have surgery or who may be at high risk of surgical complications, and some patients who may just choose not to have surgery. But I'll also show some data about patients who could potentially have surgery and whether SABR may play a role for them. And then in advanced lung cancer, as we talked about, we'll show some data for oligometastatic and oligoprogressive scenarios. I'll focus mainly on the prospective data that have now emerged in these areas. So again, medically inoperable early stage lung cancer, SABR, has become the standard of care. And that's based on a number of prospective clinical trials. This was a landmark trial, the RTOG 0236 trial, for medically inoperable patients with stage 1 lung cancer. And you can see that with a very intensive dose of SABR, the primary tumor control was extraordinarily high, 98%. The overall survival I show here as a kind of a benchmark. Remember, these are patients who are sick with many comorbidities, and so their survival is limited to a significant extent by their comorbidities. So 3-year overall survival of somewhere close to 60% is a consistent number that we'll see. And Dr. Bob Timmerman was kind of the pioneer who really launched this trial and led it. Similar results from the Nordic study group, a phase 2 cooperative group trial. And again, just to highlight, overall survival at 3 years of about 60%, 3-year local control of about 90%. So again, you'll see this consistent theme showing up. And again, the JCOG cooperative group in Japan, medically inoperable patients, 3-year overall survival 60%, local control nearly 90% with SABR. So very consistent results in different continents, different series. Okay. There have been a couple of randomized trials comparing SABR to conventionally fractionated radiation for early stage lung cancer, which used to be kind of the standard, although a poor one, and both randomized trials ultimately showing that SABR was superior to conventionally fractionated radiation in the Nordic trial in terms of quality of life, but in the Australian trial, actually superior local control and superior overall survival for SABR. Okay. So what about patients who could have surgery? How does SABR compare to surgery? And here we lack, full head-to-head comparisons, but we have some data. So these are prospective trials done in the RTOG as well as in Japan, cooperative group prospective trials, not randomized, showing, remember the previous studies of SABR showed overall survival of about 60% at 3 years. Here we're seeing about 77% consistently, and this is a different patient population. These are people who are healthier, who could have had surgery, but had SABR instead. Now you'll note here on that I'm showing the results here from the ACOSOG Z30 trial. This is a benchmark high-quality surgical trial for early stage lung cancer, showing a 3-year overall survival of 76%. So that's about the survival that we expect from high quality surgical treatment of stage 1 lung cancer. What about randomized data? We don't have a completed trial, but we have a pooling of 2 trials that were sort of individually not completed, the STARS and ROSELLE trials. And very interestingly, what we see here is a difference in survival between surgery and SABR, but the winning arm was actually SABR. Again, it's not an arm, it's not this is kind of pooling of data from 2 trials, but they were randomized trials, and SABR was actually superior in this particular analysis. Now, MD Anderson expanded the STARS trial, so no longer randomized, but they kept treating patients on the SABR arm, patients who could have had surgery, and showed consistently, again, that the 3-year overall survival was over 90%. Now, they did a non-randomized comparison with patients who had surgery at their own institution, so a highly expert surgical center treating with minimally invasive surgery, and found equally good results between SABR and surgery, both at over 90% at 3 years. So very intriguing data. A number of randomized trials are still in the process of accruing. So again, just to illustrate what do we expect from kind of the benchmark surgical outcomes, the ACOSOG Z30 trial was a high quality surgical study. 100% general thoracic fellowship trained surgeons in this multi-center trial, good quality resections, low perioperative complications and mortality for a surgical study, and the 3-year overall survival was very, very similar to what we've been seeing with the prospective trials of SABR for operable patients. But there's a cost to surgery, and this is looking at the National Cancer Database, comparing mortality between SABR and surgery, particularly in kind of the first 90 days, so sort of peri-intervention mortality. And you can see that what's shown here is a strong age dependence. So you can see that it's very similar between SABR and surgery, although still a little bit higher mortality for perioperative mortality for surgery in age 66 to 70. But as you get to ages over 80, the surgical perioperative mortality risk keeps going up, whereas for SABR, it's fairly age independent. And so I think even for patients who could have surgery, age is a good or an important factor to consider. And perhaps one could consider this for patients who are older, that SABR might in some cases be preferable. So to summarize the efficacy in early stage disease, we see very consistent outcomes across multiple prospective trials, tumor control rates exceeding about 90%, overall survival about 60% in medically inoperable patients. But for operable patients, 3-year survival in the 77% range, very similar to what we see in high quality surgical series. Whereas in terms of toxicity, all of the early trials of SABR, the early experiences had high-grade toxicities, but as the field has matured, you can see that in the cooperative group trials, really no grade 4 or 5 toxicities and low grade 3 toxicity. Whereas with surgery, although the surgical mortality in high-quality series is low, for example, 1.4% in the ACOSOG trial, that's still higher than we would expect from SABR. So let's move on to the topic of advanced lung cancer, so metastatic disease, right? So historically, metastatic lung cancer has been considered incurable almost by definition. However, as we talked about, these new clinical entities are being recognized, oligometastatic patients, some of whom have a decent chance of long-term survival and even cure, and oligoprogressive disease. So as we've been seeing more and more effective systemic therapy, I think the argument is that the role of effective local therapies will be increasing as well, because we actually amplify the effect of the systemic therapies, as we'll see in some of the data. So the standard treatment for metastatic lung cancer is systemic drugs, mainly chemo, but now immunotherapy has become an important staple of treatment, sometimes in combination with chemo, sometimes alone. And for patients with specific driver mutations in their tumors, molecular targeted drugs have become the standard of care. So the question is, in combination, can we actually increase the chance of cure in these patients who have, kind of historically incurable lung cancer? So these are trials of immunotherapy and chemotherapy in patients with metastatic lung cancer. So it's just to sort of show as a baseline. And so what these trials showed on the left-hand side, we see that compared to the standard arm of chemotherapy alone, the addition of immune checkpoint inhibition with pembrolizumab produced a pretty dramatic increase, like almost a doubling of median survival, and over 40% 2-year survival. So a dramatic improvement. On the right, we see the KEYNOTE-24 trial, and this was specifically in patients with a higher PD-L1 marker on their tumor. And in those patients, even pembrolizumab alone was superior to chemotherapy. Okay. So what about patients with oligometastasis? What's the role of ablative local therapy? So these are a couple of randomized trials in oligometastatic lung cancer who started with systemic therapy, and then the intervention was continue with standard of care versus giving local consolidative therapy, which usually was radiation therapy in either conventionally fractionated or SABR, and in some cases surgery. And the bottom line was that in these two different randomized trials, although fairly small in size, there was a significant improvement in progression-free survival with the addition of the local consolidative therapy. But looking at the longer-term results, there was also a significant improvement in overall survival to local consolidative therapy. On the left here, again, this is the trial by Gomez. On the right-hand side is a different study. This is the SABR Comet trial in patients with oligometastatic cancer from various types, but it included lung cancer. These were patients who did not have metastases at the beginning, were treated for their original presentation of cancer, and then developed metastases later. And so these patients were treated either with just standard of care palliative therapy or SABR to all of the oligometastatic sites. And again, the SABR Comet approach showed an increased overall survival advantage to SABR. So very provocative data. What about patients with molecular driver mutations? So this was a trial in China, patients with oligometastatic lung cancer with EGFR mutations. So the standard of care in these patients is to give targeted drug therapy, so tyrosine kinase inhibitors. But what they did in this trial, this was a randomized phase 3 trial, they did upfront SABR to the metastatic sites or not, followed by the standard of care drug therapy. And what you see here is nearly a doubling of progression-free survival, but also a significant and pretty large impact on overall survival. So basically an over 7-month improvement in overall survival. Now, if any drug therapy added to a tyrosine kinase inhibitor produced a 7-month increase in overall survival, that would be an approved drug. So I think these are very provocative results. A similar study also in China. In this case, they started with the drug therapy for EGFR mutated lung cancers, and then after 3 months, did SABR to all of the oligometastatic sites. So again, showing both progression-free and overall survival improvement in this randomized trial. What about oligoprogressive cancer? These data were presented at ASTRO last year from a trial led by Memorial Sloan Kettering. And it was done in 2 different populations, breast cancer and lung cancer. But if we look at the lung cancer population, so these are patients who have potentially widely metastatic disease, but responding to therapy, systemic therapy, and then have progression in a limited number of sites, up to 5 sites. And the treatment was continue with standard of care or SABR to the oligoprogressive sites only. And you can see that in the lung cancer population, this resulted in an improvement in progression-free survival, and whereas it didn't in breast cancer. And the difference between the two when they analyzed patterns of failure is that, interestingly, when patients progressed after the initial oligoprogression, in lung cancer, they usually progress first in existing sites, whereas in breast cancer, they usually progress first in new sites. And so that kind of explains perhaps the difference between the two responses in between the 2 diseases. Okay. Another new direction is, as in locally advanced lung cancer, the addition of immunotherapy after chemoradiation has had a dramatic impact on improved survival. What about for early stage cancer treated with SABR? MD Anderson recently published what they call their iSABR trial, or immunotherapy plus SABR. So far, they don't have the overall survival results yet, but in terms of event-free survival, the addition of pembrolizumab after SABR for early stage lung cancer produced a pretty dramatic improvement in event-free survival. So again, kind of a provocative new model, and we're now testing that approach at Stanford with a more personalized approach where we're using circulating tumor DNA as a selector for whether or not to give the adjuvant immunotherapy. So that's led by Joel Neal and Max Dean. It's called our ADAPT-E trial for early stage. Just very briefly, I'll touch on what about, we talked about non-small cell lung cancer. What about stage 1 small cell lung cancer? Historical, we have no randomized data, but the data from Japan suggests that we get actually pretty reasonable outcomes in small cell lung cancer treated with SABR to the primary tumor. But what you see is that there's likely an important effect of adding chemotherapy. So small cell lung cancer has a higher risk of systemic dissemination. And so it's probably the combination that's optimal, SABR plus chemotherapy. Again, just retrospective multi-institutional data showing that the local control after SABR for small cell lung cancer is very high, in the 90% range. Overall survival with small cell lung cancer is not as good, but actually similar to what we saw with the medically inoperable patients with non-small cell lung cancer. that the impact of adding chemotherapy appeared to be important for reducing regional and distant metastases. Okay, so we'll come to our survey question now, which is, in randomized trials of treatment of oligometastatic lung cancer, definitive local therapy, especially SABR, has been shown to improve which of the following: progression-free survival only, but non-significantly, or statistically significantly, or progression-free and overall survival non-significantly or statistically significantly. So I think you can go ahead and answer the survey question now. So very good. I think the majority of people answered the right choice, which is we do now have data showing both progression-free and overall survival is significantly improved in oligometastatic lung cancer. All right. So just a little bit more showing just some of the data that, learnings that we've gained from our own institution here at Stanford. We started SABR for lung tumors using single fraction SABR on the CyberKnife platform. And from that original phase 1 data, kind of looking at it retrospectively, what we found was that single fraction SABR to the doses that we used was very effective for smaller tumors, but it was really inadequate for tumors that were larger in volume, so GTV greater than 12 ml. Okay. So we changed our treatment paradigm, where smaller tumors we continued to give small, kind of modest single fraction doses of 25 gray, whereas larger tumors we switched to multi-fraction, higher dose intensity treatments. And what we found retrospectively was that adaptive approach eliminated the difference between larger and smaller tumors. Okay. In addition, we found that the multi-fraction dosing regimen that we used was safe enough for use in both central and ultracentral tumors when we were using highly conformal image-guided techniques with very sharp dose gradients. In addition, in the setting of lung metastases, we found that colorectal cancer metastases really stood out as having higher local recurrences after SABR. And so we changed our practice to using higher doses for even small colorectal metastases. And so that led to our prospective trial that was just published. This is our Stanford iSABR trial, where I stands for individualized. So you can see that we binned tumors into different size categories, small, medium, and large, and we use different dosing regimens for each one. We also adapted the dose for different locations, central versus peripheral, and also by histology, where colorectal tumors could not get the lowest dose for small tumors. And so you can see the schema here and examples of the different size categories, small, medium, and large. And our publication shows a lot more of the data. This is just one of the summary results, which is that our overall survival in the different cohorts, so primary early stage lung cancer, or multiple early stage lung cancers, or lung metastases. Actually, our 3-year overall survival was in kind of the above 70% range. So actually quite a bit better than the historical results for medically inoperable patients, even though many of these patients were medically inoperable. And you can see that our local recurrence rates were kind of in the under 10% range for all the different categories. And when we analyze it further, because we use the individualized approach, there was no difference based on size or location or histology, other than in this analysis, we actually found by adapting the dose, the colorectal tumors were very well controlled, but squamous cell histology actually stood out as being a little bit more resistant And so now going forward, we are using higher doses for squamous cell tumors. Okay, so my last example for SABR is this case where the patient had locally advanced left upper lobe tumor with nodal disease and a large primary tumor, but also an oligometastasis in the adrenal gland that was biopsy proven. And in this case, we gave concurrent chemoradiation to the primary tumor and nodes, and SABR to the adrenal gland. You can see this is the treatment planning scan showing the primary mass and the metastasis, and then 6 years, and actually now the patient's like 15 years out, cured of stage 4 lung cancer. So as a case example. And then the patient 9 years after initial treatment developed a new stage 1 lung cancer that we treated with SABR and is now cured of that as well. So so the take-home messages for SABR are that it's now standard of care for medically inoperable patients with stage 1 lung cancer, but it is an option for some patients with operable lung cancer and also for small cell lung cancer. And I think we're going to see kind of an increasing data on improving survival and maybe even some cures in patients with oligometastatic lung cancer and benefits in oligoprogressive as well. So the combinations with targeted drugs and immunotherapy are certainly promising, and we've definitely seen a paradigm shift. So question number 2, based on the clinical studies that we talked about, which of the following factors are prognostic for local recurrence after SABR for lung tumors? Breast cancer histology, FDG PET SUV, tumor volume, or ERCC1 or 2 mutations? Please go ahead and answer. And again, great job to the group. So tumor volume in our analysis really was the one that stood out. Histology, again, what we've seen is colorectal cancer histology and squamous cell histology appear to have distinct responses. Other histologies really, in multiple different series and analyses, do not stand out as different from each other. And some newer data on mutations from Max Dean's group suggests that KEAP1 and NFE2L2 mutations may be indicative of radioresistance. So that's the best answer I would say at this point for this question. Okay. So just wanted to spend a few minutes on locally advanced lung cancer where chemoradiotherapy and now adjuvant immunotherapy is the new standard of care. And that was established from these trials here. So up until recently, kind of our benchmark for the best results that we've seen in clinical trials for stage 3 lung cancer with chemoradiotherapy was the RTOG-0617. And then the Pacific trial showing that with the addition of the adjuvant immunotherapy with durvalumab, there was a significant improvement in overall survival. And so you can see that the chemoradiation arm of the Pacific trial had outcomes very similar to what was seen in the best results of RTOG-0617. But with the addition of adjuvant durvalumab, there was a 13% absolute increase in overall survival at 4 years. So now we're seeing 4 to 5 years survival results in stage 3 lung cancer exceeding 40%, getting close to 50%, which is just really unprecedented in history. So that's very encouraging. What about the techniques? So in RTOG-0617, an analysis of those patients who got IMRT versus those who had 3D conformal radiotherapy. This was not a randomized assignment. In fact, it was unbalanced because the patients who got IMRT typically had larger, greater tumor disease burden, probably because they had a larger disease burden, and to avoid toxicity, IMRT was used more often. Still, even though IMRT was used for more advanced stage 3, the survival outcomes were very similar to the lower stage tumors treated with 3D conformal, but there was significantly less grade 3 radiation pneumonitis, about half the rate of radiation pneumonitis, better ability to complete chemotherapy, and lower heart doses. So IMRT really should be considered the standard of care in this setting. In terms of what volumes to treat, one of the historical questions has been, should elective nodes be treated as we do in some other cancers? And a number of randomized trials looked at this. This is probably the most definitive one, is the PET plan trial, where patients were randomized to treating PET negative elective nodal regions or not, and found that while there was no difference in overall survival between the groups, there was an actually improvement in local regional control in the patients who had no elective nodal radiation, so just involved field alone, which allowed actually giving a higher dose to the smaller volume without excessive toxicities. Okay, so in our own experience at Stanford, we've analyzed local tumor control. This is Mike Binkley's publication on a per lesion basis, finding that that metabolic tumor volume per lesion was a predictor of local control with larger tumor volume, not surprisingly having a higher rate of local recurrence. And in addition, there was some additional information added by the metabolic tumor volume at the mid-treatment point in chemoradiation. So this kind of opens the possibility of adapting the radiation on a per lesion basis to metabolic tumor volume. And just looking at our overall results, using concurrent chemoradiations, this is actually results before immunotherapy, but using slightly accelerated radiation. So we commonly use 66 gray in 30 fractions of 2.2 gray a day. Our results show a good local recurrence rate of only 24%, compared to the 34% that was seen in RTOG 0617. And in fact, there seemed to be a benefit of doing the accelerated radiation, where giving at least 2.2 gray a day, our local recurrence rates were as low as 17% out to even 4 to 5 years. Okay. This is complicated treatment, and so just like with surgical therapy, there are data that that expertise really does make a difference. And so 3 different analyses, the last one on the right side being from the RTOG 0617 trial, showing the difference in overall survival between patients treated at a lower volume center versus a more experienced higher volume center. And you can see that there was like a 6-month survival difference between the 2 groups, which again, I mean, if any drug therapy gave you a 6-month survival advantage, that would be an approved drug regimen. So it just kind of illustrates the importance of the technical quality, experience, and overall clinical management. Okay, so question number 3. In RTOG 0617 for stage 3 lung cancer, IMRT compared to 3D conformal was associated with improved overall survival, decreased radiation pneumonitis, decreased cardiac toxicity, or improved tumor control. Please go ahead and answer. Okay, so this is a tricky question because I think there were multiple potential endpoints here, but in fact, overall survival was not as increased because the groups were imbalanced. IMRT actually had more advanced tumors, and so the overall survival was actually about the same. Radiation pneumonitis was the key finding of the benefit of IMRT on that trial. Decreased cardiac toxicity, we don't quite know. We know that cardiac dosimetry was better with IMRT, but the analysis on actual cardiac toxicity was not published. So B is the correct answer for this question. All right. So finally, in the last couple of minutes, I just wanted to mention work that we're doing to clinically translate ultra-high dose flash radiation to the clinical setting. And what we're really interested in doing is not just ultra-high dose rate, but highly conformal flash treatment, kind of getting all of the conformity, hard-won conformity that we've achieved with IMRT over the years. And so really what that requires is a new class of accelerator technology, which, as it happens, was invented by my colleague at SLAC National Accelerator Lab, Sami Tantawi. So this shows conventional linear accelerator design, but where each of these accelerating cavities are adding energy to electrons that travel down the central aperture. But what Sami discovered really was by studying the properties of the cavity shapes and materials properties and so on, that optimizing the shape of these accelerating cavities can dramatically improve the efficiency of transferring the radio frequency power to the electrons. And so that can be used in multiple ways. Basically, with the same power sources, you can get higher energy beams or much more beam current. And so this was a prototype design that with further optimization, we estimate can allow the beam current in linear accelerators to be about 30 times higher than what we have in our current clinical machines. And so by arranging an array of them around the patients, so this is just showing kind of our current treatments. Here's a 25 gray ablative dose of radiation being delivered in a little over 3 minutes. The concept that we're developing, this phaser concept, would deliver the same ablative, highly conformal dose in a fraction of a second. And what you see here is an array of these next generation linear accelerators providing nearly simultaneous beams from all these different directions at a total of about nearly 500 times the beam current, so that the whole treatment can be completed much faster, freeze the physiologic motion, and also take advantage of flash biological effects, which will be the topic of a future talk. But also we're aiming to design this in a way that is very compact and economical compared to the existing technologies. So I guess that's a teaser for future talks. I want to leave enough time for Z to talk about planning and technical aspects, and just want to thank my clinical colleagues in thoracic oncology that I have the privilege of working with here. So with that, I will transfer the time over to Z.
Excellent talk. Thank you so much. That was quite amazing.